We're here at the NACHC CHI, and I'm talking with Dr. Brian Anderson, President and CEO of CHI. And we're so happy to have you talk about this new NACHC partnership. But let's start with the basics. What is CHI?
So CHI is a nonprofit that started in March of 2021 as a coalition of the willing. It was started principally by doctors and technology companies that were in the middle of the pandemic coming together, wanting to come up with a common definition for what responsible AI looks like in healthcare. It's grown to now be a formal nonprofit. We have over 3,000 organizations. Really excited to be partnering with NAC in the future AI space.
Well, it was really exciting to learn that you once worked at a community health center in Massachusetts, Greater Lawrence Community Health Center. How does that experience inform the work you're doing now with the NAC partnership?
Yeah, so working at Greater Lawrence Family Health Center, I think one of the things that really impressed upon me was the challenges that the patients had to go to the health clinic to receive the care that they needed. Oftentimes, patients had to take 2 or 3 bus transfers just to get in. These are individuals that are working 2 or 3 jobs a day. And so the challenge of just making the time to come into the clinic was an incredible obstacle. My hope is a lot of these technologies, AI, and some of the tools that are being built using AI can meet patients where they are at, enabling an improvement in access to care.
Excellent. And you've talked about how important it is to have a common definition about the responsible use of AI. Tell me a bit more about that and if that's an organizing principle behind this work with NAC.
Yeah, so one of the exciting things about CHI is that we bring together a bunch of different stakeholders. You have technology companies, big and small. You have health systems, big and small. You have patient community advocates, and you have government officials at the federal and state level. When you bring these different stakeholders together, particularly when you bring the developer community and the customers that they're trying to build products for, namely CHCs in this case, and you put them down in a working group and say, we want to come up with a common definition of what good, responsible use for AI for CHCs looks like. What you're doing then is you're essentially giving the developer community a target to build towards, that their customers have essentially said, this is what we're looking for. So one of the hopes in partnering with NAC is that you're empowering that voice of the CHCs and the patients they serve to help the developer community understand the tools that they need to build for. And so hopefully in doing that and building this common definition, we're going to lead ultimately to the innovation community building more impactful tools that are trained on the data sets that come from these communities and that serve these communities as tools that are leading to more effective and safe healthcare.
I'm going to jump in here because I remember you talking so eloquently about how it is so important for these data sets to reflect the populations served.
Yeah.
And that is one of the goals with this collaboration.
Exactly. I think, it's very hard as a physician, if you're sitting in a room with a patient, to be able to answer the question, is the tool that I'm about to use appropriate for the patient I have in front of me? And with AI tools, that's even harder because there's a level of opaqueness in terms of what data sets were used to train this model. In CHI, one of the principles is this principle of transparency and this concept of an AI nutrition label, where a doctor, a nurse, a patient can understand what data was used to train this model on. And so if I'm a doctor and I know that this patient that's in front of me is a representative patient from the data set that the model was trained on, I can be more confident that this model might actually perform really well. The alternative to that is that this patient is not representative of the types of data that was used to have this model trained on. And in those cases, it may be a risk that the model doesn't perform well on the patient I have in front of me.
I heard you share wisdom that every time there's a digital innovation, there is also a digital divide. Can you explain that?
Oftentimes, the tools that are made in digital health are built to serve the early adopters. And the early adopters are usually more resourced, larger academic medical centers that have more funding around them to buy and to use expensive digital health tools. The challenge with AI is the same, or it can be the same. If the tools that are developed with AI are built using data sets that only come from academic medical centers where you have highly educated urban patients, you're missing a whole opportunity to serve a community that has less resource, CHCs. So part of the hope in the partnership that we're bringing together is, one, we're enabling the voice of the CHCs to be more loudly heard, right? Giving the innovators the target. And we're working with groups of CHCs through PCAs, through HCCNs that can come together and in a shared service way enable their data to be ready for models to be trained on. If we can do that, then the innovation community will very readily, very willingly want to make use of that data to train models that they can then be used to serve those communities. And so that's, I think the real excitement about bringing groups together as part of PCAs or HCCNs, where those data sets can be engineered in such a way that they're still privacy preserving, but the AI models can be trained on.
That's a perfect wrap up for this conversation. I want to thank Dr. Brian Anderson for joining us at the NACHC.